Thanks very much. I'm delighted to be here. Marmot is another landmark in understanding health inequalities, following on from the Black and Aitchison reports. The English Review, Fair Society, Healthy Lives, builds on the work of the Global Commission, Closing the Gap in a Generation. The evidence highlights that health inequalities arise from social inequalities in the conditions in which people are born, grow, live, work and age. These conditions lead to an accumulation of both disadvantage and health hazard throughout life, with early childhood experiences having the most profound lifelong effects. The stress and lack of control that results from disadvantage and adverse circumstances leads to poor mental health and poor physical health. The Equality and Human Rights Commission reported recently, and they concur, geography matters, as does socio-economic circumstances. Incidence of ill health is closely associated with areas of deprivation, particularly amongst those under 65. These persistent social inequalities are interwoven with disadvantage of gender, ethnicity, sexual orientation, disability, age, religion and belief. There is a wealth of evidence that shows that education is a key determinant of life chances. Boys, some ethnic minority groups, and those eligible for free school meals, which is a proxy for those children living in poverty, become less well performing at a remarkably early age, at 2.5 to 3, and I'll show you the evidence later. This doesn't happen by chance, and joint strategic needs assessments around the country show that deprivation is generating poor social, economic and environmental conditions in specific communities. This leads to poor health behaviours and poor health outcomes. Health inequalities, which are reasonably avoidable by policy means, are, in the view of the report, unfair and unjust. A senior American politician, when Michael presented the report in New York, said, "I've read this report and it's nothing but ideology with evidence." And we follow the same pattern in the English report because we think it's important that we have ideology that's backed up by the evidence. Let's look at some of the evidence. Sorry, gone 2 slides. This shows the achievement of the past decade, but also our failure. What you see, the yellow line steadily rising upwards, is standard life expectancy, and we've increased it for all groups. Even those spearhead PCTs with the worst health in the country has risen by 2.9 years in the past decade, and we need to pat ourselves on the back. We're doing something right. But what we're also doing is something wrong. And what you actually see is a widening gap between those people in the spearhead PCTs and the English average. The gap rose 7% for men and 14% for women, and that was one of the issues that we needed to grapple with in relation to the review. There is a clear social gradient in health, and that's what this chart shows you. The pink line is standard life expectancy, and the blue line is disability-free life expectancy. You'll notice that the gradient is much shallower for the pink standard life expectancy line. The difference between standard life expectancy for the poor and the rich is just about 7 years. The difference in disability-free life expectancy is 17 years. So the message is, those who are poorest in our society die sooner and they're sicker longer before they do. The green line across the middle is a commentary on social policy. The green line is at 68 and represents the new retirement age. And what you'll notice if you look along where the green and the blue line converge, by the time people get to retirement age, 65% of people have a limiting illness or a disability. If we want to get people to work longer and retire later, we're going to have to make sure we do something about keeping them healthier, because at the moment we're not managing to do that. Oh, sorry. What we do know is that inequalities accumulate across the life course, and they relate to socio-economic status. That advantage or disadvantage is reinforced from generation to generation. And in particular, the evidence will show that education inequalities have an impact over the lifespan and not just in education. Difference in participation in education persists throughout life and impacts on life chances, on wealth, on access to housing and poorer health. There's a clear social gradient in relation to educational status. It is not by chance that graduates are significantly healthier than those without qualifications. And again, I'll show you the evidence in a moment. In the review, we developed our conceptual framework, which started with reducing health inequalities and improving health and well-being for all. And I bet you sit there astounded saying, and it took them 14 months to work that out. Okay, let's unpack it a little bit because there's some important issues in here. Firstly, reducing health inequalities is obvious, but the next is the critical interlinkage of health and well-being. And well-being in particular is a very important construct that we need to look at and that we need to foster and that we need to build resilience in our communities in order to improve health and well-being, because it's the well-being that comes first, and the lack of well-being is the stress indicator that leads to ill health. The second is health and well-being for all. You've seen the social gradient, and what the social gradient says to us is that all of us lose out. It's the very richest in our society that have the best health. And along the gradient, we all lose out proportionately. So we're all in this together. And a very important message that came out. We then have the issue of creating an enabling society where people maximise their potential and participate. And some thoughts about that. Empowerment of individuals and communities is a critical part of our democracy. But then we'd have to explain why it was that in the 2005 election, 50% of 18 to 25-year-olds didn't bother to vote. We'd have to explain how it is that only 25% of MPs at Westminster are females. We'd have to explain that disadvantaged communities feel a greater lack of trust and safety. And Wanless warned us in his report on the NHS in 2004, unless we secured a fully engaged community, we would not be able to afford the National Health Service by 2040. And it's not a message that we've heard, but it's one that we need to hear and take action on. We adopted on the right a value base of sustainability, social justice and equity, because we believe that ideology is important and that it's supported by the evidence. We then look at our 6 policy objectives in yellow. Give every child the best start in life. We believe that we should increase the proportionate spend in early years, that we need to support families pre- and postnatally. We need routine support and support for parenting skills. And Frank Field's report and the Sutton Trust report in the last couple of weeks emphasised that parenting has declined in the past 30 years and that we need to do something to support parenting. We need to support the transition into school, and we need quality outreach from school in order to ensure that children have the best start in life. We need to maximise capability and control for young people and adults. We need to prioritise life skills as well as academic achievement. We need to concentrate on communities and the family and not concentrate on schools. The impact of schools is incredibly limited. What defines educational attainment is the support of families and communities and peer groups, and we need to build some bridges between schools and into extended communities.